It is wonderful to have our new panel with us. We have Dr. Laxmaiah from the ICMR National Institute of Nutrition. We have Dr. Bhavna Sharma from ITC's Nutrition Science Department. We have Ankita Marwaha from the Nutrition Science Department of Pepsico. We have Seema Jindal Jajodia from Nourish Organics, Dr. Rajan Sankar from the India Nutrition Initiative at Tata Trust, and we have Dr. Meera Agnihotri from the WWW Foundation for Women Empowerment. Thank you all for joining with us for this afternoon, the last of our sessions for this summit. We were closing off the last session with 3 fundamentals. And I want to repeat that, and then I know that we'll be focusing on one of them. We said that if you can get a good night's sleep, you have one major component of your health covered. We also said that if you can get around and not sit on a chair for 8 hours a day or more, you are in a much better place than you otherwise would be. And the one thing in between, what we said was, if you can eat right and well, your triad is doing pretty fine. That should leave you feeling better in your body. It should enable you to get up with a smile. It should enable you to interact with your neighbor and your spouse or your children or your parents with a lot more of positivity than otherwise if you were not sleeping well, or if you had aches and pains simply because your body was not in the right shape. For this hour or so, we have experts. Many of them have got nutrition science and nutrition, all of that. In fact, we have a National Institute of Nutrition head also with us, all focusing on nutrition. And I want to kind of begin by opening this conversation with you, Dr. Laxmaiah. The last session, somebody did mention about the newly unveiled NFHS 5 results too. And only to point out that while we have increasing amounts of food available in this country, it does seem that we don't eat as much or well, because anemia among women doesn't seem to be going down. It seems to be creeping up. And that seems to be a problem. So also for children. What is it that we should be doing that would change that trajectory?
Good afternoon, sir. Shall I start, sir?
Yes, please, sir. Yes. What should we do to change that trajectory?
Yes. Good afternoon. So, Dr. Baby John and Dr. Shankar and all my co-panelists, and I'm very much privileged to join with you. Very eminent experts are available now. So, because all are involved in the nutrition and welfare and good nutrition status of people of India. Actually, sir, as you said, correct, because recently even NFHS 5 results also out for 22 states. Another 14 states we are waiting. But in that, we are definitely we are suffering from triple burden of disease in India, because one is undernutrition, PEM, including child stunting, wasting, and other things, and third and second one is mostly majority of people are suffering from micronutrient deficiencies and hidden hunger, and almost throughout globally more than 2 billion people are suffering. But in India, half of the people are suffering from one or the other micronutrient deficiencies like iron, iodine, and vitamin D, B12, and recently we have also studied B12 mapping in India. Surprisingly, B12 is not that much problem, but it is the problem is more than 1/3 of people are suffering from even B12 deficiency. So the concept of well-being. So the concept of well-being may not be applicable everybody now at present situation, because and the different grading of people is living in India, because the one blanket type of advice or recommendation or supplementation may not work, because different groups of people are there. We have to handle, or we have to start interventions with a different type of population, that different nutritional grading. As you said, because the three things are very important. That one is the sleep, and another one is good food, balanced diet, and third one is physical activity. Indirectly, what you said, sitting 8 hours in one chair, and that may not be possible. We can several advices are there, but every 1.5 hour, everyone should stand up, and just 5 to 10 minutes you have to walk here and there, and again you sit.
Right.
But how many
Dr.
people
Laxmaiah,
are
I'll
walking?
hold you there.
Yeah.
I'll hold you there, sir. I'll hold you there because you've said two things, and then I wanted to kind of deflect that to Dr. Rajan Shankar here. One, you said the concept of well-being may not be applicable to all everywhere in this country because the data kind of tells us that there is something wrong with how people are in their nutritional status. And you said also that one size may not fit all, which is the same intervention may not be useful everywhere. Dr. Rajan Shankar, you've got years of experience. You've worked with most people here on the panel too. I mean, where do you take those two comments that Dr. Laxmaiah has kind of pointed us to? And how do you square it with the data and what do you see
Okay.
moving forward?
You can finalize. I can sign.
Dr. Laxmaiah, if you can mute your line, please. Dr. Rajan, yes.
Hi, thank you very much, Robbie. I must first tell you that you've given us a new way of looking at it. I really like the way you put the triad, and I'm sure many of us will take it forward. It's a good way to look at it. Yeah, coming to the point that what Dr. Laxmaiah said. See, we know that we have a major problem, and the recent data again shows at an aggregate level things are not improving very much. But what I might take from what Laxmaiah said is that these aggregate figures hide more than what they really reveal. We need to look deeper. We need to see where the problem is. Who are the section of people who seem to have greater proportion of this problem? So because there is a wide variation. There is, the vulnerability is on many counts, the dominant one being socioeconomic. There are also geographic vulnerabilities. There are also certain social exclusions, unfortunately, that continue to be prevalent. So the vulnerability is what would really make it worse for certain section of people. So this one size fit all, those who need it most are the ones probably are left behind. I would just take that as that's the message I take from what Laxmaiah said. So therefore, my recommendation based on that would be, we need to identify pockets with serious problems. We need to identify vulnerable population in vulnerable geographies and target interventions to them. Only then we can make a far more rapid reduction in malnutrition in general. And then the question on anemia, we can take it later maybe. Thanks.
Right. So you're saying, sir, that we need to, one size does not fit all. We'll have to understand the vulnerabilities more specifically, look at how these pockets are, and then devise our interventions in such a way that it makes the biggest difference for them, rather than having a lowest common denominator approach, which may help a specific number of people, but may not address the problems where they are the most acute. If that's a way that I would kind of paraphrase that.
Absolutely. You see, at the current maturity of the programs, you see, when India started with universal programs and trying to reach everyone, the problem was far more. Even though we grapple with the very severe levels of malnutrition, they've come down dramatically in the last 30 years, though they're still very, very high, not in any way defending that. At that stage, that kind of a program to reach everyone was welcome. Now at this rate, we need to really make some course corrections. As we continue with universal programs, greater targeting would help. It's not either or, we need both.
And so if I were to kind of translated into numbers, if we had, say, given 750 districts, we may have the equivalent of about, say, 200 districts where the problem might be more acute, and these 200 are not geographically concentrated, they are distributed around. And even within those, it would be probably one or two talukas that are widely distributed again. And so therefore, understanding where the problem is really matters. And this is where, I mean, from an earlier conversation that we were having, understanding the geographical or geospatial distribution of malnutrition becomes critical. And the geospatial distribution also will tell us the cultural or other barriers that might be actually there accentuating vulnerabilities, which is where I turn to Ankita, Marwaha. Mothers know when their children are not doing well. Okay, long before anybody else can kind of tell that the child is losing weight or things like that, mothers have a sense. They also have a sense of about themselves. We all have a sense of ourselves also, that we are probably not doing well, especially when our intake is lesser than optimal. It does not matter whether you're kind of not skipping a meal. The fact that your plate size itself became smaller is evident to you. Where do you see individuals? We have been talking at the big district level, state level, country level. Where do you see the individual level actions changing this story? Is there a scope? If there is a scope, how?
Sure. So first of all, thank you, Dr. Bobby John, for having me here. And I would say it couldn't have been a better afternoon, a pleasant one than, sharing the panel with Dr. Shankar and Dr. Laxmaiah. So I would say that it's a very interesting aspect which you have brought up. I believe, they say that, any change starts from self. And of course, every individual today nutrition is all about, I think, self-management. And while we are talking about increase in awareness, raising that awareness, but how much it is really translating into individual action is something. If I just give you, a broad example of what we have been doing now, if we take specifically iron deficiency. So we did an intervention and we reached around to 1 lakh school children. And what we found is that the knowledge, even this basic aspect that you need to squeeze lemon to increase the iron absorption, was such an aha and wow for so many mothers and children as well. And when they took that, we had a control group where, this information was not existing at all. And we had another group where this information was existing. But the information remained constant with everybody, right? But ultimately, the mother and child who really went and continued to, take it as a habit was very different across regions, across schools. So this primarily it tells that we might talk about awareness, lack of awareness, or we might talk about government not taking action, but it ultimately boils down to how an individual really looks at nutrition and starts taking those significant actions. So that's how I will put it.
Right. Thank you. Thank you so much, Dr. Ankita. And I'll continue this conversation around and we'll come back. Let me turn to Dr. Laxmaiah. Dr. Laxmaiah, how does this, if you can go back to elaborate on, if one size does not fit all, how does it kind of work? Do you think it's going to be exclusively driven by the public sector, or is there a role that you would see now for the public sector to work with the private sector? Because what's happening at the plate level is not merely determined by what is being provided by the PDS. It's also being determined by what people are spending out of pocket and personal preferences. How do you see that change? Dr. Laxmaiah? Yes, sir.
Thank you, sir. Just before I said that, because different people are suffering from different nutritional deficiencies, like 3 major kinds, because they require different action points and interventions level. Because one is undernutrition, another one micronutrient malnutrition, and third one is a lot of people are suffering from non-communicable diseases. So we have to address separate section wise, because then only we could bring all those people at one healthy population level. So then one first segment of population is required for, even some people are not getting even food security and nutrition security. And some section of people, the overconsumption or some one or the nutrients overconsumption also leads to non-communicable diseases like HFSS foods, like high fat, sugar, salt, and those kind of problems also there. So ultimately, if you want to bring all the groups in a wellness level, so we have to work with different levels of approaches. Then only we could make them people happy and the well-being of the people. So that is my point. Another your question is, even only alone government cannot do all these things. Even it is a multi-stakeholder approach only we can do. Either it may be private sector or public sector or NGOs, and everybody in a convergence manner. So then only we can approach. And another thing also there, lot of programs are there, wellness programs also there, and elevation of poverty programs also there, and elevation of nutrition programs also there. And people are doing in silos and different sectors and different points, but there is no togetherness. So we should bring first in one togetherness, and everybody should work for in the same cause, but there is no connectivity in between. Because this kind of event, you see, this kind of event webinars and other things, even I have attended in 1 month more than 20 programs, but everybody intention is same, but there is no connectivity. So if you join hands, everybody, suppose somebody is working on undernutrition only one specific area, all should combinedly work. Even that will give a very good result. And whatever our goals are there, even sustainable goals, even 2035 is there, even our Poshan Abhiyan goals, so 2022 is there. If you want to achieve all these things, the convergence is very, very important. And even though we are speaking 20 years convergence, nothing is happening. And sometimes it may happen in the grassroots level, and sometimes it may happen in the secretary level, but in between everything is missing. So that is my I want to focus on these issues.
And that's very, very sharply said, sir. That we've been working for over 2 decades, and yet we are yet to converge on this is how we need to work together. All of us are saying that we need nutrition addressed, and yet when we go back home, we are working in our silos, and it does not work. I mean, in fact, even on a food plate, I mean, you don't eat just the cereal once and then separately you kind of take the protein, and then separately you then they all come together. I mean, as all good Indian platters will kind of show us, things come together and things should come together. But the awareness that things should come together in a balanced form, in an adequate form, seems to be less of a reality. How do you get this real nutrition awareness, Ankita, Marwaha? How do you get that at again, I'm going back to the individual familial level, because from there only we can kind of pull back up. And if there is a deficiency in real nutrition awareness, then we kind of address the gaps. How do you go ahead?
So I think, like I mentioned, it's more about the behavior change. So when a mom and a child are on the table, the most important aspect is that the child is seeing the mom and the family and the elders what they are doing. And you might they might hear about carbohydrates, proteins in their science books. But when they come at home and they see that they are being asked to have a lot of vegetables, but probably grandparents or father, mother, they themselves are completely not having a certain food groups. So I think role modeling, starting from that table of family itself, is a very important aspect. Second, I would say that when we talk about, it's not just about getting proteins, carbs. So nutrition is sometimes just looked at as getting X amount of things, achieving 50% RDA. And so I think it's not about those numbers. It's also about how it is achieved, because the mindfulness is so very important. When you are watching TV and eating, you don't have your mind what you're eating at all, right? But parents will be talking on the mobiles and having food, and that's how the whole family is eating today. So I would say that again, that the view to nutrition, besides those numbers, and suddenly if the trend of immunity goes up, everybody. So we saw that during this last 8-9 months, the search on the word immunity has gone up by 500%. So when you're talking about one particular aspect, the entire world looks at only that one dimension of health, or there's one miraculous ingredient and people will think that we are having that, and nutrition is taken care of. But that's not how. So I think the other change is not just about education on nutrition, but these hows are equally important. And third, I would say, is the thing which is important is that whether we are evolving with changing times. Because typically as educators, or typically as people, why those synergies at times don't happen, because we all might have the same objective, but our hows differ a lot. And then our hows are so different that we are very fixated, and this is how the nutrition should be achieved. If there is a dietetic community, they will say that no, you should be eating only the whole form of it, completely forgetting the practical aspect of it. If you would have, say, a working mother like me, we would want, can you give us some simple solvable things which I can apply on a day-to-day basis? So till the time we come up with simple, workable, practical hand-holding solutions with sustainable approach to it, I think the interventions won't be that effective. So that's my view.
Dr. Rajan, where do you take that from where Ankita has kind of left us?
Yeah, it's actually very well said, Ankita. I agree with most of what she said. But I also would like to build on what she said. Much as it is important, the point that she was making is a lot of nutrition has to start at individual level, at family level, at community level. Now, the facilities that the government they create access where most of what they give is generally product based. You come to me, I'll give you a vaccine, I'll give you an injection, I'll give you a medicine, I'll take care of ABC. But then the decision to practice things happen at individual level, therefore at family and community level. So if we have to build this, though we've been focusing on what we call behavior change communication, now they've added it as social behavior change communication. All that is important, but what we should really aim at is changing the societal norms for certain things. Where do a poor mother, it's not always the knowledge about a thing. They just check with their peers as to, have you vaccinated your child? What do you do after a pregnancy? And what's your breastfeeding, behavior? So it's not always, it would always help to equip them with adequate knowledge, but that alone will not suffice. We're not making enough effort to change social norms. See, when social norms change, the community as a whole would try to live up to that and change their things. And you can really, if you dig deep and look at the data, you'll find in societies certain behavior move in a herd fashion. So for nutrition, we need to just move away from this. Much as we'd like to do at individual level, equip them, we should also make a lot of effort to change the social norm. That's what I would add to what Ankita well said. And also on
Right.
that you asked, yeah, right.
Right. No, so I'll just want to hold up, because there is a fascinating nugget in the NFHS 5, which I kind of, for me personally, I kind of picked up because when I started off my work career, I stayed in a village, and I was kind of always fascinated by this young woman who would be brought by an older person in her family. Probably that's the only time that I would see her in those days, which is, doctor, she is pregnant, she needs that teacup. When I look at the numbers right now, we are well over 90% into coverage for tetanus toxoid in antenatal populations. And that tells me, I mean, what you said just now is important. It was a single thing, of course, to be relevant. The messaging was very, very clear. The social side of it was taken care of. Everybody knew that a pregnancy meant a tetanus tika had to be given.
Hello?
Can we, but it was easy to administer because it was one thing. Nutrition is not just one thing. Nutrition is 365 days, 3 times a day, and many, many more things. And so it becomes that much more tougher to manage. How do we build this social? I mean, yes, there is the individual thing. There may be the aspiration. There may be the individual level actions that are required. But how do we provide the supportive framework that allows for that translation to take place? Both first Dr. Rajan and then Dr. Laxmaiah on that.
Yeah, thanks, Bobby. I mean, I don't have the answer. You know, I think you picked the right one to say something which people weren't taking at all, tetanus toxoid, and then you see it has reached, optimum coverage. That's a good thing. So, we need to do, it's a package. It's not that, of course, there are a number of things.
If you can just hold on a second. If you just hold on a second.
Am I audible?
Yes, Dr. Meera, you're audible. And I will come to you next. I will come to you next. Right.
So, hello.
Yes, please go ahead, Dr. Rajan.
Yeah. So what happens is that it's a package. Even if we change the social things, a number of things are not happening at individual level, not necessarily for lack of knowledge or lack of willingness to do, but there are many other constraints that come. It's not just to know what is the right thing to feed a child, but you may not be able to, it's the access, affordability, a number of other things come. But still, I think we should try to move the societal norm as a whole. All those who are able to practice such a thing would automatically practice. That's a point I'm making. I don't think that's a solution, but we're making very little effort on that. We're focusing more and more on individual things. To say on the point which Laxmaiah so brilliantly said, that, he said it very well, that we need to learn to work more and more together. Even within this nutrition package, there are several people. There are people who have only one size hat to sell. They will try to fit it on the head that it would fit. See, that's a problem. We need to go with the package. We need to make it available to the people, accessible to the people, and people will practice within their constraints and remove the constraints as we learn and understand.
Who better than a person from the corporate sector, especially putting out different packaging sizes, to know or comment on how to put different package sizes or different product offerings in front of people, so that both individual behavior is achieved, and also that there is a wide variety of choice available, or specifically available for different target groups. Welcome, Dr. Bhavna Sharma, to the conversation. This has been going on for a little bit, and we've been talking about how to make nutrition both available to those that need it the most. Dr. Laxmaiah has very succinctly put it, one size does not fit all. And the last comment that you heard from Dr. Sankar was, you may have to package it differently. And that's why when I saw your screen pop up, it was very easy for me to kind of flip to you. Because from your world, in the corporate sector, you know the science of packaging and the science of targeting. How do we address the pockets of undernourishment or malnutrition in the country right now? And then we'll kind of then flip to the other side, which Dr. Laxmaiah has earlier on pointed. It's not just undernutrition; we are also seeing the other side of it too, the overtake or the over nutrition side of it. But let's take the targeting of undernutrition, please.
Yeah, thank you. First of all, apologies for coming in a bit late. But I think, I think I did join it at a very interesting point where you guys are discussing about this whole packaging. And I think, as you rightly said, we have that saying, you don't actually eat the food when you actually eat it. You actually eat it the moment you see it. You actually make your choices much before you actually even holding a piece of, a sweet, or, even roti, or anything it's been made at home, or anything that you see it on the shelves. You actually see it first and then decide whether you want to buy it or not. So I think when you say, there are two aspects of it. One is the entire packaging, which is the whole communication, the colors and the schemes and the way it is written, what you choose to highlight, or what an FBO chooses to highlight on it, and I think I always take this example, because we're talking about both under and over nutrition at the same time. And I'm talking about, the time when, I think when this whole HFSS and, front of pack labeling and all those discussions were coming in, where we have to put in calories and energies and all those things. Okay. I remember being part of some of the discussions with the in their homes, where actually how they flip their decision making on buying something. So if you actually say on like a carton of milk, plain milk, and if you just put it out to say that, it is low calorie milk, and she said, yeah, actually what, I would like to buy that. Thank you for making it for me, because I think I can manage my life better and things like that. You just flip it and you say it's low energy. It's the same unit, right? She said, how can you even think of making, milk which is low energy? How can you even think about all those things? Starts from the fact, which is the communication, the claims, the whole packaging. It also goes to the fact, like you were talking about. Yeah, I think someone.
Go ahead.
So basically what happens, when we talk about, packaging or the pack sizes, the universes are actually very, very different and apart from both under and over nutrition perspective. So when you're talking about, if I would like to probably assume that, in the world of the whole over nutrition perspective of it, the pack sizes, the communication, the claims which are written there are actually, people like to believe that they read it, but a lot of them don't even understand what's actually written on that. Even today, if you talk about it, people don't know the difference between, sometimes fiber, prebiotic fiber and a probiotic fiber, and what is going to be a TDF. As they start to happen, they start making a big change. When you talk about nutrition, I think that's a whole new different world, because there, I think a lot of people are not even at the scale of, even being able to read what's written on the pack. I think they're just going by the visual, or they're going by the, like the national, like a samachar that goes, or it's part of some campaign which is led. You have to actually explain the benefit. And actually, I'll tell you one thing, when you talk about those communication, it has to be one communication, a pack that is usable, a pack that is smaller, a pack that is, is affordable. So we always talk about this fact. There's accessibility, there's affordability. In that, we have to manage the nutrition credentials of a product. So I think, it will be completely unfair on my part to say that, these two things can be solved together in one sentences, because the kind of people, the kind of communication, even the pack sizes, like you were saying, because the cost in the purchase, because we always do the cost versus value, equation in our heads, they have to be tackled very, very differently from each other, so that when it was made, the intent for which it was made, the target group it was made for, it should reach them in the right way. And the language, like I said, even the visuals, the colors, what's written on it, how it's communicated, is it part of a national intervention program? And I think foremost is that any intervention program that we do should not take people away from buying something extra, buying something expensive, introducing a new food habit, and making them do something which is out of the ritual, because then that's never going to get accepted, no matter what you do on the outside. So I think there are some fundamentals in place that have to be put together. And I think, sometimes I say that, when I work, it's so far easier for me to make a research project and, do a CSR intervention or a sustainability initiative and knowledge. The moment you introduce a product education intervention model into it, it completely takes to a very complex dynamics, because you want the benefit to reach, but to do knowledge plus product together for the right benefit for the right target group is actually very difficult. And I think we have to do it, very thoroughly from step one. I hope I've been able to give So on to that
Sure,
part.
sure. You're just kind of bringing it to very, very sharp relief. On my screen, I have Ankita, Marwaha, and Bhavna Sharma on one side, and I have Rajan Shankar and Laxmaiah on the other side. I mean, literally, I've got two sets. And it's almost like there are two different vocabularies right now that, as Dr. Laxmaiah kind of right in the beginning said, we need to figure out how to bring together, to converge. There's the specificity, there is the targetedness, there is the almost, how should I say, packaging that seems to be missing, or that seems to be less evident in how we are approaching the National Nutrition Mission or the Poshan Abhiyan, or how we kind of engaging with the small groups which are large in the aggregate, but are small enough that they are lost in the larger context. How we get to them. How can the two sides work together? Dr. Laxmaiah, I mean, you've made the plea that 20 years we have been talking convergence, we have not kind of worked together. How is it going to work together?
Sir, I already said that because the convergence is there. Convergence is at grassroots level. Suppose A&M is there, then Anganwadi worker is there, ASHA workers are, they are working with convergence. But at a secretary level also, there is a convergence. Secretary and additional secretary, some high level. So, but there is no in middle level there is no convergence, because until the middle level convergence is achieved, then only we can that percolate into action. Actually, that is not happening.
Can you give an example of what the middle level convergence would look like?
Middle level means are direct program managers. Suppose just example, one or two things, some ICDS if you take, ICDS and health and social welfare. Okay, so I am working since more than 20 years in ICDS, MDM and other nutritional programs. But what we found, there is a gap, lot of gap in those between is, but there is a grassroots level. Anganwadi worker is working, helpers are there, then ASHA workers are there, then village volunteers also working together. But at the same time, there is no convergence between medical officer and CDPO and DPO. I'm taking just one example. It may be in several sectors also this is happening. So until unless if the immediate managers, the program managers and our program implementers, if there is no convergence, because nutrition, as you know, it is a multi-sector approach only we can achieve, because one department and one individual cannot do anything for improvement in nutrition, because nutrition depends on several factors. So either it may be production, agriculture, or health service, healthcare, or it may be social welfare, or it may be education. So several sectors involved, because until unless if all these, we also categorize into three things. One is a primary stakeholder, then is another one is a secondary stakeholders. So primary stakeholders, at least 6 departments identified by the government of India, and from nutrition National Institute of Nutrition also we recommended these are the primary stakeholders should together work. Otherwise, until unless if togetherness is not there, we cannot achieve the common goal. So that is my point. And another point also discussed is several experts, like even at individual level within family also the distribution is not equal, because we have published 2-3 papers on intra-family distribution of energy, protein and other things. There is a lot of gap, because if you take overall at a household level, enough calories are coming from whatever food they are consuming, but the calories distribution is not equal. And you will be surprised, because 2 adults are there, 2 children are there. We have specially analyzed in children food what is the intake of their energy, protein and other things. And surprisingly, we found even poorest of poor families, we found that the adults are getting adequate energy and protein, but at the same time the children are not getting adequate protein and energy. Why it is happening? Not because they are grabbing from children and eating adults, but it is a ignorance. There is no nutrition literacy. Even people say that you increase the literacy, automatically nutrition literacy will not increase, because nutrition illiterate, even illiterate people also nutritionally illiterate. So we have to improve. Education is very important, and we have to convince and promote this equal in the equal distribution of food and adequate balanced diet. And recently we published one book, What India Eat. So in that book, we have mentioned all what regional wise, in individual wise, what is the difference. And we have also developed my plate. So what the ideal plate should be. As you correctly said that our plate is reducing or other thing. But we have this, my plate is a very good example as a balanced diet. And we have compared with my plate recommended diet and what is actual intake. There is a lot of gap. There is some excess nutrients also there. There is a less nutrients also there. That should be balanced. So then only it will be happen as you aspire that well-being.
Right. Thank you, sir. I mean, because Dr. Laxmaiah, you've kind of so clearly kind of spoken about the places where the convergences need to happen. But a lot of the convergences that you are speaking about are still within the government or the public sector. The plate is not entirely filled by the government sector. The plate is filled by offerings both from the public and out-of-pocket private expenditure too, right? To greater or lesser extent. How does that convergence happen, and how do you kind of leverage the capabilities of targeting or the capabilities of packaging so that the plate, as you so eloquently puts it, and I'll come back to that because it's a great picture. How does that get addressed? Dr. Rajan, how do you kind of bridge that?
Thanks, Bobby. I think that's a very important question. The first, we should realize people don't look at government for food needs. You know, if you take, and we're also rapidly urbanizing, more women are in workforce, and we're no more a subsistence agrarian economy. More people are getting into cash economy. All this means people are looking to the markets for their food needs, and more will look. And we're also rapidly urbanizing. We tend to say, when we think market, we tend to equate it with big, multinational companies and packaged food. I think that's the first thing we should take out. They are part of a much bigger market ecosystem. And in countries like India, they're actually a very small part. You know, they may drive changes in terms of food safety and how it should be packaged and what is good for a lot of our things. See, who trades with food? There are only 3 states in the country that do not import wheat. There are only 3 states that do not import rice. There are only 3 states that do not import, edible salt. So there are lots of the private sector that moves and makes food available. So there's no question that they play an important role in filling our plate. So there's no question. So let's not put it only to the packaged big multinational. Now, when it comes to that, I think very unfortunately, this tri-sector partnership of getting government, private sector, civil society, much as we know that it is required, it also comes with a lot of difficulty. I personally had many disappointing experiences in the past. It doesn't seem to be working, but it has to work, and that's the only way solutions will be found. One of the most recent attempts is in India, the UNICEF, the Tata Trust, they have come together with some, NGO CSR box and trying to create what is called Impact for Nutrition. We brought more than 100 private sector partners to come together and just do what the National Nutrition Mission has asked the private sector to do. It's not about the product. It's about, what they can really bring. And I think all the sectors they have deep suspicion of each other. The private sector thinks that the government is inefficient. The private government officials think that the private sector is only for profit. I think gone are the days. Everyone is looking at a sustainable way of doing business, sustainable way of, improving the welfare of, things have gone. Everyone, the people in your panel come from background where they're looking at triple bottom line. So I think we should somehow breach these, artificial bridges, bring everybody together to work, and only then we will be able to reach the benefits of science as well as what private sector can bring, and reach it to those whom I said initially need to be targeted. We can't leave the most vulnerable to the government and just leave the private sector to take care of those who may not really require all that advice.
Right, and that's wisdom, and that is experience for us who are listening on the audience side. The elusive goal of getting the three sectors to work together, the necessity for making sure that in some way or the other it happens, but also recognizing that it is not the exclusive domain of one or the other to fill the plate. At the end of the day, the plate is financed by the individual who's in front of whom it is, because they pay both their taxes, even if they are not directly paying it, and they're also paying it out of pocket. So really speaking, the plate really is being paid for by the person. It's not being paid for by somebody else. And in many ways, figuring out how to make sure that it is wholesome, that it is affordable, and that it is readily accessible all throughout, and with no disparity within the family, as Dr. Laxmaiah kind of pointed out, that the adults get an adequate proportion of it, and the children get left out simply because they don't have adequate information. And this is where I turn to Ankita Marwaha. Conversations around information at the family level, and also the zeitgeist of what being healthy means, or what eating healthy means. What are the millennials thinking, because we are seeing malnutrition among them too, both on the undernutrition side, the number of children that are teenagers that are showing up with lower calcium iron levels, or also on the overnutrition side with body mass indices really not where they should be. What is happening there?
So I would say for millennials, what we have observed is the definition of nutrition to them is all about weight management. It's about extremes of nutrition, extreme of exercise, extreme of a quick fix. Everything needs to be quick fix and achieved now and here. Again, that broader concept of nutrition is missing. It's not about nourishment of the feel of aha, or the feel of I'm great, but the nourishment of real body, mind, soul, which you were talking about some time back. So that nourishment concept, the nutrition concept, needs to be understood more holistically by the millennial population. We would say that literacy, we did one research, and cereal being an integral part of our diet, we thought that because and that too millennial population in metros with an SSEA kind of consumers. When we went to them, 1,000 of them, only 20 of them knew what whole grains were. And some of them, they said that even white rice is whole grain, a significant proportion of them. So they were eating white rice considering that's whole grain. The concept was this looks whole, so that's whole. So how it was viewed was so beautifully different, and even simple things like this made us realize that it needs a lot of education. No matter how much claims you will put that this has so much of whole grains and X, Y, Z, but every person is understanding with their own way of looking at it. And suddenly we are seeing so much dialogue on intermittent fasting and the fat diets. So I think you will. Yeah, so I think probably the holistic nutrition is something which this millennial population definitely can achieve through their knowledge and being so digitally savvy. And as I would say for this population specifically, like I mentioned, instead of quick fix, how can we evolve them into a more sustained living concept is something which will be very critical.
Thanks, Dr. Meera. You've seen women, say, 3 decades ago. You're seeing people who turn up into clinics today too. What's different in their concepts about nutrition, good food, say a few decades ago to today? Do you see any changes? And do you see changes in the people themselves? I mean, in terms of the nutritional status of women that were coming into clinics, say, 3 decades ago to today?
As far as I understand your question, you wanted to tell me about the nutritional status of girls and women 3 decades back, and
now, what is the change that you've seen? What is the change that you're seeing now?
That's a lovely question, and a rather more important question to be put before patients, before teachers, before practitioners, and also before the politicians, and also those persons who are charging and making diet and nutritional protocols, guidelines, and so on and so on. So it's not a question for me, it's a question for all to solve. The most important thing which I like to tell you, 3 decades back, our girls were not that empowered. And empowerment is one thing which is very important, as we keep on telling them, swasth, shiksha, swavalamban, samajik ekta, samvedana. These are the things which were not there in our society earlier. What we used to learn that, unlike what was told by earlier speakers, I was not present earlier, much before. So only thing which I used to notice that when the food is there, suppose there are 4 chapatis, it will be given first of all to the head of the family. It will be given first of all to the boys. It will be given first of all to the, you see, those who are earning members. And women and the ladies and the girls were the last person to get it. They will not bother whether these women are healthy, they are anemic, their iron level is low. I believe that we received patients even at 4 grams, gasping, panting, and asking for help during pregnancy. And they have prepared food before they come to the hospital. Then attendants will be telling whether she was all right, she has prepared food, she has attended the kitchen, and now she is lying. Will you believe it? A girl or a lady with 4 and 5 gram hemoglobin must be preparing food for the family and has not taken anything and is coming to the hospital. So these were the things which we were observing earlier in a bigger proportion. And the level of the anemia, 3, 4, 5, incompatible anemias, we are exchange transfusions are needed, they are extending up. It's not that. But unfortunately or fortunately, in our country, the level of the anemia, in spite of our fight, right and left, from every level, right from Anganwadi to so many other things, and so many rules and regulations framed by our Honorable Prime Minister and government, we are not able to come out of the crisis of the anemia. And if it was 50%, 2 out of 1 girl is anemic, 2 out of 1 girl is, maybe that a decimal change is there this way or that way. But we have not come up with a substantial improvement in the treatment strategies. So earlier, we were fighting for anemia. When I was a student, when I was a lecturer, when I was a reader, all through, and today, when we are dealing with all these things, we are fighting with anemia, anemia, and anemia. One thing which is very important to tell, to convey, it is not only hemoglobin, it is not only iron which with we are fighting, it is not one element. We have to look for the holistic approach. We must convey what we were telling our girls, iron ki goli dena or folic acid ki goli dena, and that asha worker and seva workers and all these are ki 100 goli deni hai sarkar ki. We have to tell them they are having hypovolemic anemia, they are having hypoproteinemia, and the children which they are producing, they are so deprived of it. Intrauterine growth restriction, intrauterine growth retardation, mental deformities, congenital deformities, they are rising like anything. So past and present, if I compare, anemia level was always there. A little decimal change from this way to that way there. We have not conquered it in spite of so many efforts by the government and the private sector and the hospitals which we are running. So we have to look for it. We have to go for the holistic approach. And this holistic approach, we have to tell this is the palm, you have to divide it 4. We have to know what are the micronutrients, we must know what are the macronutrients, what are the essential nutrients. And we have to tell our patients what is the difference between nutrition, malnutrition, undernutrition, and overnutrition. Because a different class of the societies, You see, the babies are coming to us, they are full chubby and getting everything, and then the chocolates are being kept inside the mouth of these girls. So they are chubby, they are having PCOS, they are having diabetes since beginning. So holistic approach for nutrition must be there. I'm happy to inform you that in the medical colleges, we are working very hard on the ethics and research centers in collaboration with the IITs, and we are preparing and telling our patients with a chart over there that it is not iron alone which will work. You have to take protein also, you have to take calcium also. Why calcium? Why iron? Why this thing? So now they are understanding, and we are having these Garb Sanskar classes also for our patients so that they may have what we really want. So a holistic approach is required, and a typical guideline in Hindi and any language, regional language is required for the patients. ऐसा नहीं है कि उनको थर्ड ट्राइमेस्टर में है. They have to be told before pregnancy, during pregnancy, first trimester, second trimester, third trimester, and thereafter when they are lactating. It's not a blanket statement कि आपको 2 रोटी ही खानी है. We have to tell why you have to take more when you are lactating. We have to tell why you have to take this thing in the first trimester. These are the things should not be taken. That is what. So these are the changes which I personally feel they must be put forward categorically, telling that these are the guidelines for this period, these are the guidelines like this, and these guidelines we are putting into the antenatal box. Going to the schools, adolescent health has to be told to them. And there are different guidelines for the adolescent health, right from menarche, early adolescence, late adolescence, and so on. So this is my point, sir.
Right. No, please. Meera ji, thank you so much. I mean, there are 2 things that I want to kind of hold out to the audience. I mean, that I captured. She said 5 words. 5 Sakar. Swasthya, Shiksha, Samaj, Swavalamban, Samajikta. Correct, madam?
Yeah, they are the one.
Correct.
These are the important things we have to catch up.
These are the 5 things that she said. And then I want us to kind of pay attention to each of those words because they mean something in the context of our communities.
Right.
They mean something for us as individuals and how we kind of go forward in holding and bringing up the nutritional levels. The way she kind of pointed out, and I have personal experience, I have delivered a woman of her 5th baby at 4 grams %.
Right.
I had seen her only when she came in for her delivery. I did see her once again for her 6th baby. She almost died. Right? And that was only 25 years ago.
Right.
We haven't moved that much. The second point that she's making is absolutely important. It is, yes, iron and folic acid are important, but not to the exclusion of the overall protein intake. If you do not have between 0.8 grams to 1 gram of protein per kg body weight, and I've done a rough math on this, by 2050, if we are assumed that we have 1.5 billion people in India alone, we'd be requiring close to 30 million tons of purified protein per annum. How on earth are we going to deliver that? Because that's purified protein available. How on earth are we going to deliver to the point that Dr. Meera Agnihotri has just pointed out? Not merely hemoglobin, but the overall availability of protein so that the body is better nourished.
Right.
So that the body is better strengthened. And that will require, again, to go back to what Dr. Laxmaiah started off with, it has to be a multi-sectoral approach. It cannot be one or the other. You will have to have an agricultural signal that prioritizes protein outputs. How do we do that? Are there private sector mechanisms? And I know that Dr. Sharma's organization has got these chowpals that are now being established across the country. We need to figure out models like that allows for farmers and our primary producers to produce a variety of things. We prioritize cereals because we wanted calories. We've got a surfeit of that. And we've got the problems of over-calorie intake in a large proportion of our population too. How do we correct that balance? How do we ensure that there is adequate protein? Because if we don't have adequate protein, even as early as the first trimester, by the 8th week of gestation, we will begin to see impact intrauterine for cognitive development.
Right.
And those are things that we cannot really correct for outside of the uterus. It has to start a long time before. And in doing so, a simple question that I've been asking that I have not had an answer to is, do we know the average birth weight of a baby by district? That should not be a hard number to ask. It will tell us exactly what the mother has been eating, what the family has been eating, what's available in the community. A birth certificate is a legal document today, and so the recording of a birth weight is also happening. Why is that number not available on a real-time basis, which would allow us to go back to an earlier point with Dr. Rajan was saying, of the 750 districts, it may be only 200 districts, which may be spread across 35 states. And in the 200 districts, there may be only about 2 talukas each that may be kind of actually dragging everything down. If we knew where the birth weights were low, wouldn't it be a sensitive, albeit a tragically late indicator to tell us where to focus our efforts? Would that be the place where we would get a better targeted marketing, packaging, communications, and generally nudging the mothers and the community to better frame their plate? Dr. Laxmaiah, how do you want to kind of take that conversation into the convergence that you have been so eloquently crying for?
Sorry, I missed it, sir. Which point?
So I'm just saying, how do you kind of take that convergence into seeing actions on the ground in the places where they're most needed, in the places where Dr. Meera is describing that women are still coming in with very low, with anemic profiles?
Sir, in several forums, we discussed about because some program monitors or program implementers are there. They are implementing the program. But the monitoring, close monitoring, supervision, concurrent supervision is nobody is doing. So because from the beginning, we are recommending the government and all development sectors that there should be some independent monitoring and evaluation system some vertical system should be there. So then only, because now apna baby wo sundar lagta hai. So if same department is implementing, same department is monitoring, everything seems to be good, and it is just like a good well approach. Not like that, because if I am implementing the program, somebody external body should come and inspect periodically whether this whatever inputs are going or not, whether what is the gaps are there in this program, how to rectify this program. So that kind of some independent monitoring and evaluation should be there. Then only the convergence and those things will be happen. So if you talk about convergence, another 20 years also it will not happen, because until
Dr. Bhavna, how do you see this convergence happening?
Wow, it's a see. I think it's a tough one. It's most required, but I think what Dr. Laxmaiah just said, I completely second it. See, I think we all have been trying our best to work together on these things. We also know they are extremely important. And I probably would probably say from the size that we have been working from, I have also seen this kind of programs and, kind of a dependence on each other to actually take those things ahead. Initially, there used to be a lot of, pressure for, organization spending that 2% about doing some kind of a good thing. Can do a CSR, okay, do a CSV, encourage, adopt, educate, and just sometimes you do it with all your heart and sometimes you're not doing with all your heart. And then I think over a period of time, with this whole nutrition, public health information, with the data sets now becoming available for us, like you just said, I think a lot of people don't realize exactly what you just said, that important, critical, missing data set, right? Like my own PhD, I had done it for vitamin D and calcium status for the Indian pregnant women and its impact on the neonate at 40 weeks. And, I collected the cord blood and I collected the, blood at 40 weeks and things like that. And I actually realized that, by the time I'm taking the data for the infant at 40 days, sorry, not weeks, 40 days, it's too late already. It had to be done much before the woman was even thinking of conceiving, and things like that. And why was it not told? And this was, picking up women from the lowest strata, because they are the ones who are actually, bearing the brunt of the whole thing. From the public health coming onto the, then I realized that, there is a whole new word of brand sustainability initiatives that have come, and each organization have picked up their own SDG goals and stuff like that. Today, I think from whatever little experience I have gathered in the last 15, 20 years of my work, today I see from where I come from is that brand or the organization sustainability goals are somewhere directly or indirectly linked to these kind of things, which are solving two things at the same time. They're also bringing about a lot of communication, a lot of transparent information sharing, within an organization to get, aligned on these things which are happening outside, and they know they cannot survive without it, because you have to work towards your country, your countrymen, and the planet and the community as a whole. And it also helps the cause on the other side. And the various people who would not even probably have thought of nutrition or health and these kind of words are actually talking and discussing in the boardroom and saying, how do we make it better? Because our organization is now linked to it. So, like I said, it's going to happen differently when you're sitting in a boardroom versus when you're going to be sitting, in a government office. But I think what Rajan sir said some time back, it has to happen. Some people are a little ahead on this journey. Some people are getting onto that thing, but it has to happen. And if it doesn't happen, I think we all were eagerly waiting for the NFHS 5 data to come in, thinking we were going to get a little smile on our face in this terrible year of 2020. But unfortunately, it didn't happen. Today we are talking about, anemias in the children and the obesity in the, thing. They're still going from bad to worse. So I think there is something seriously missing in the work we're doing. And we seriously need to take this ahead to make it a lot better than what we've seen this year.
Ankita, Marwa.
So I would say that again, we want the conversions. We all have that intent, and we are seeing. I would say that I have seen some very unique programs which were not happening in India earlier. I would talk about if you look at UK, there were salt reduction program where the government had the same campaign, the consumer organizations were talking about the same, so the pitch was same, and even the companies were having the same pitch, versus I would say probably if an IM is saying my plate, I go and as an organization talk about it in a different way. So when we have the broad messages like most of us spoke about, if we know that we have a common theme and our articulation and language remains the same, and so that's one way probably we can align. The FSSAI came up with a lot of programs, the Eat Right. So that's a mission. So again, there is a whole call to action being given with that whole nomenclature and bringing all the groups together. At least that dialogue has started. So we have definitely seen those actions emerging which were not happening earlier. So I would say that gradually we are moving into that direction. This panel itself, thanks to you, we are openly talking and discussing about these aspects today. That again shows the progress we are making. But 2-3 tangible actions probably at a broader level with this kind of a panel approach from various sectors where everybody signs to a common theme plus 2 clear actions and say how each one of them can contribute in their own ways could be very meaningful. Those could be few conversion points from my end.
Now, those are helpful for us to take on. Meera ji, what is your recommendation? How do we move forward?
I personally feel that we all are fully aware of what we should do. The only thing is how to do it. Everybody is knowing that this is done. I've heard Dr. Sharma talking about the vitamin D. It is one of the very important research which was given to our student. And the anemia, so-called anemia. Vitamin D is one of the deadly duo to transform iron. She will be agreeing to me if she has done this research, to transform iron at the bone marrow level much before it is needed to convert it into proper erythropoiesis. So these things are coming up. I'm very happy that she has put it. This deadly duo must be known. What I want to tell, I know, and everybody is knowing that this should be done, this should be done. We have already framed guidelines, and these guidelines in any language, wherever it is used, must be given to the lowest person in the simplest language to be translated and transformed to the patient. If I say, "Tum do roti khana," the other asha worker goes, नहीं तुम एक ही रोटी खा लेना. So there must be a guideline कि this is the plate or this is the proper this thing, 1/4 must be this must be the amount of the protein. और protein जरूरी नहीं है कि बाजार से biscuits आप ले आए, that is the protein which is needed, should not be. हमारी जो ladies हैं, they are not very rich. अगर हम उनको गुड़ आयरन के लिए, चना देने के लिए, if we recommend it, that is one of the best thing which we can advise. Suppose I am a poor person, you advise me charcoferol, you advise me iron tablet or 20, I will never be able, I will throw this prescription into the waste paper basket. Whether whosoever is the obstetrician or gynecologist, I will not be able to buy it. But if you very clearly tell me that madam you can take this thing in the morning, आपके घर में ज्वार हो रहा है, बाजरा हो रहा है, और तुम्हारे यहाँ किसकी खेती होती है, then they can jolly well translate. So we must know what we are prescribing, how we are prescribing, whom we are prescribing, and at what stage we are prescribing. And these guidelines must be kept on our table. We are doing it in our medical colleges. These guidelines for adolescent girl. Adolescent girl में menarche में उसको क्या देना है, different. Early adolescent में क्या देना is different. Late adolescent में देना है क्या different, because the hormonal changes are there. So we only know, and if these things are told in a very simple language to the even our Aya, she will be able to tell, yes, जैसे डॉक्टर शर्मा ने बताया कि नहीं ये गोली भी जरूरी है लेने के लिए, और जरूरी नहीं कि सब चीज गोली से हो, आपके घर में ये सामान है, you can take this thing, you can this thing. One of the doctors, Doctor, I can tell you, in our college, he has made a laddu for poor patients. Basket भर के वो ले जाते हैं. उसमें मुझे I don't know the contents as well. For the adolescent girls, जो स्कूल में पढ़ने वाले बच्चे हैं, उसमें चना मिक्स करा है, उन्होंने गुड़ मिक्स करा है, so many other things. And it's a very simple thing. जो घर से एक रोटी भी नहीं ला सकता है बच्चा, उसको अगर हम ये दे दें. If we are talking for very high class, it is a different prescription. If we are talking to middle class, it's a different prescription. And if we are giving it to those, we must know whom we are giving, whether they are utilizing our prescription or not. So that is the most important thing. And these guidelines must be framed. हमको मालूम है कि हम मूली खा के भी ये काम चला सकते हैं, गाजर खा के भी चला सकते हैं, चुकंदर खा के भी चला सकते हैं, और बड़ा सा that huge 10 रुपए की एक गोली से भी चला सकते हैं. तो we must know whether this गोली is to be utilized or not. आपने एक पैकेट गोली दे भी दी तो वो कितने दिन चलेगी उसकी. तो we must convey in a simple language what is nutrition, what is malnutrition, what is undernutrition. हमारे माँ जो है वो complete circle है, उसको nurture भी करना है, उसको absorb भी करना है, उसको बड़ा भी करना है, उसको lactate भी करना है, उसको feed भी करना है. So we have to tell it in that simple way to our mothers, and these guidelines must be kept before everybody. उस guideline को किस language में किस तरह से transform करना है, ये हम लोगों की duty है, those who are connected with the patient one to one. This is what I feel, sir.
Meera ji, thank you so much for capturing many of the things that had been spoken, which brings me back full circle to Dr. Rajan Sankar, which is that one size does not fit all. There are vulnerabilities and exclusions that are different in different places. And so therefore, like Meera ji so eloquently put it, the same prescription does not work everywhere.
Very true.
It will be different. It will be differentiated approaches. And it will have to be tailored to the need in front. Seems to be a tall ask in a very large country. We are 1/5 of humanity. Proportionately, we also carry the largest or over-representation of the nutritional underperformance. What do you see the 2020s holding for us in our trajectory towards addressing malnutrition and detrimental nutrition in our country?
Thanks, Ravi. I think, it's been very instructive listening to the people. And I would just touch on one that repeatedly came up as, say, the convergence. What we mean is that, this problem that we're talking about is multidimensional. There are many causes, many of them interrelated. Therefore, the solutions also have to come from different sectors. After all, we've created the sectors and silos only to improve performance of each sector. So it's very difficult to breach them. They function very well. What is needed, it's based on an evaluation by Professor James Levinson of some of the successful multisectoral programs, He clearly said we must bring sectors to sit together, plan together, work on an agreed framework, go back, implement sectorally, come back, take stock multi-sectorally. Then, that's what we have to somehow understand. On the question of what we have for 2021, I think even this recently released NFHS 5, there are lots of successes that we see. There are very many bright spots. The children are living longer. The more girls are in school, more girls are staying in school. The age of marriage is, going up. The age of first childbirth is, moving up. The BMI of women as a whole in the country is going up. Of course, at one extreme it's going, but and the low birth weights, which you referred to, is coming down. The water and sanitation has improved tremendously. The food availability is there, but it's only a question of creating that access through policy instruments. So let us not get fixated with just one anthropometric indices of saying they're important. I'm not trying to wash that under the carpet, but there is a lot of good things that are happening. Maybe we need to persist, we need to target, and we will see a quick jump. This is a country which, as a medical student, I had seen children coming with, the eyeball coming out. I mean, that kind of keratomalacia, you would know, and, Professor Meera would agree with me. We've just all that is past. Though we have that anemia level not moving at aggregate level, like what Madam brilliantly said was, she doesn't see so many women coming with 4 and 5 grams. Within the anemia, people have moved from severe to moderate, moderate to mild. So, there is a lot to celebrate. We should learn to celebrate our success, but at the same time, ask for more. And I think we have the fantastic infrastructure in terms of health and ICDS. We don't need new intervention. We should correct the implementation failure. We should change the seeking behavior of our population to go and seek and utilize and own these centers. And I think with this infrastructure, with the right programs, with change in the thing, and all the sectors playing their role, that breach has also happened. We're looking more at a tri-sector partnership of government, business, private sector, the civil society. I think we are in for good time. We will see very rapid reduction in time to come.
Thank you.
Dr. Sankar, thank you so much. Thank you each for sharing candidly and from your wide variety of experiences. It's also sometimes a privilege for me to look at people's backdrops. One of them in this panel says there's no substitute for hard work. I mean, that's you, Dr. Sharma. Yes, there's no substitute for hard work. It just tells us that despite all that we have done, we still have a bunch of work ahead of us. And each of us can be champions of change. We have to work together. That's Dr. Rajan Shankar's backdrop. In our spaces, from our spaces, we'll have to respond to the challenge and the call that Dr. Laxmaiah had placed several times over. You cannot work in silos. We'll have to bring convergence together. Multiple sectors will have to work within the government, across sectors, the tri-sectoral partnerships that Dr. Rajan Shankar has pointed us to. When we do that, we will begin to change some of the mindsets that people will have, whether it's the mother in the village or whether it's the millennial who's got a little bit of cash in her pocket. What do they choose to spend it on? Will they understand that it's readily available things or easier available and yet affordable things that make the most difference, vis-a-vis something that might be on trend but does not really add value to them? We also need to figure out how we communicate not only to ourselves at a community level. Again, I go back to that 5 S's that Meera ji pointed us to. we'll have to understand that swasth is important. Swasth can be sustained with shiksha, particularly among the girls and women, gives rise to samaj, gives rise to swavlamban, and we need to have that samajikta around so that nobody drops out.
Very true.
If there's somebody going hungry, or if there is evidence of a child or a mother not doing too well, then it's humanity that we hold them together. The social safety nets are there from the government side. That needs to be supplemented by good neighborliness and convergence of many intentions so that we will not have another round of conversations looking at yet more dismal numbers on either anemia or on malnutrition and malnourished babies and stunting, which really eats away our demographic dividend. It's been a privilege to have this rich conversation with each of you, Dr. Rajan, Ankita Marwaha, Dr. Bhavna Sharma, Dr. Meera Agnihotri, Dr. Laxmaiah. Thank you for your time. For those of you that joined us in this last hour's worth of conversation, I hope you've had food for thought, and more than thinking, you will act. Thank you for joining us at IHW.